In a mandible, we prefer 3 because even with 3 there is more sufficiency that the surgical guide stays in place. So see, these are all of the standard size. They are not implant specific. Sleeves are never implant specific. We have a standard diameter of 5 mm or 4 mm. What varies inside is this part. This is known as the drill guide. That drill guide is very system specific. Like I have one drill guide for noble eye care. I have one set of drill guides in the set. The set which exactly correspond to the drilling sequence of the implant system. So for example, now this is a noble eye care. The first drill would be a 2.0. So this drill guide basically reduces the inner diameter of the metal sleeve to a 2.0. So you put this like a key, like a chavi inside, hold it in place and you drill through. So the metal sleeve 5 mm diameter becomes 2 mm from inside and you pass through that. So still you can't deviate because you put in a sleeve inside a sleeve and you're drilling through. And the 2 mm means you see how snugly it fits in. Like you see this, I put this in place. When I drill through this, there's hardly any play for the drill to go. Means you still your axial, there's no tilt. It's some tight there. So you go once in and once out, you have to follow that path. You will need longer drills. I was going to come to that. It's because when you drill, if you want to put in a 10 mm implant, that means you're drilling 10 mm in bone. Your drill will almost be 15 or 16 mm. It's because of the soft tissue thing. You're drilling through soft tissue plus the thickness of the metal sleeve. So metal sleeve thickness plus tissue thickness has to be added to that. That means that if you're drilling it with the metal sleeve thickness is going to go 4 mm or 5 mm, then you have 2 mm of tissue thickness. So 4 plus 2 6. So you will be actually drilling till 16 to get a bone depth of 10. So you need to have longer drills which are also available. There are generic drills which are now available for guided surgery which are longer than normal. So once you're finished with the 2.0, then we'll go with the subsequent drill. So basically it's just like putting the key inside and then drilling through it. If you ask me, it's quite easy. So in fact there are some videos where I have 2 handpieces going on my side. Now don't ask me if I'm holding the video. Sometimes I do. Once the ankle pins are stable, I literally do with 2 handpieces. I saw somebody doing it and I started doing it. So the guy in Israel, he does with 2, they do two osteotomies, 2 drills in it. So I said, let me try it. Because once it is through, then there is no movement. Even if the patient moves his head, your handpiece is going to move with it. Everything is going to move with it. So everything is symbiotic. Forward. Yes, this is 3.7 diameter now. So you can see that the inner diameter is wider now. So this was for placement of 6 implants. So 3.7, 13 mm implants were placed. The implants were, all the osteotomies were completed. We removed the fixation screws. Implants are never placed through the cervical guide. There is only one implant system company which recommends that we place our implants also through the cervical guide with noble guide. Otherwise, normally, as clinicians, I would always prefer to remove the guide and place my implant. Once this is giving me the path in the direction, its purpose is over. I think the actual placement of the implant should manually be done after removal of the cervical guide, because we want to see as to whether we have countersink every implant itself. See, when we do a mucoperiosis lap and we raise and place an implant, like we do conventional surgery, we know as to what the bone depth is, how much we have placed, submerged the implant, whether it's gone in completely or whether it is exposed or whether it is countersunk. Here we will not come to know anything because of the tissue. So we won't be able to see it because we are not seeing it in relation to the bone. We are seeing the implant positions in relation to the soft tissue. You will understand what I'm talking about. See, now what you see is gaping holes like this. So when you put your implant inside, you don't know exactly as to where you have to come and stop, at what position, at what level. So that basically makes it more difficult that if you have the vertical guide in place, the implant will go in through that, but it doesn't make any sense to do that. Rather, go manually on one implant for each area, take it in and shoot individual IFAs to submerge the implant completely. You need to take individual RVGs or X-rays just to make sure that the implants are completely flush with it. Because there are times when we think that it is gone completely, then we look an X-ray and then we realize that, oh no, it needs to go in another millimeter more. this is done, the post-operative once the implants are in place, the bleeding is completely stopped because the only site from where the actual bleeding hematoma was happening was the USA connection. So basically the implant itself acts as a plug, and once the implant is completely bloodless, this is immediate post-op surgery, like being recorded live at the time. So we immediately, instead of putting on the, since it's not bleeding, we're going to be giving a patient a fixed prosthesis, which is through retained. There's no harm in taking implant level impression at that time. This is not imperative that I'm going to be loading this implant immediately. Flapless surgery doesn't need to be confused with immediate loading. Flapless surgery and immediate loading are completely two different things. I can do a flap surgery and do immediate loading as well, and vice versa. But in this case, the advantage with the software is also, one thing is that since I had the data where my implants are going to be positioned freehand, I can convert the same STL data and convert it into CAD data, and I can have a temporary prosthesis also ready before I've done the surgery. That's the best part of this application, is that you have a prosthetic, a provisional prosthesis ready even before your implants are done. Patients wonder how, why. Even dentists wonder how can a prosthesis be ready before we have even done the surgery. But it is possible because a little mismatch here and there, but we can have a temporary denture which can be screw tightened onto the implant immediately post surgery. I'll tell you how. Very simple. When the surgical guy came to me, I poured a model of it. Once the model is poured, then actually I do a mock surgery on the model, and I place, instead of the implant, I place my implant replica, or the analog. And on that I can always fabricate the abutments and fabricate a prosthesis. That prosthesis will definitely, with some minor adjustments, fit in the patient's mouth immediately, chair side. This is an immediate impression which is being taken for a chair side close to a technique. For a screw retained prosthesis, we don't need a special tray, or we don't need something which is tissue contoured or a special tray, primarily because it is a completely implant stabilized prosthesis. This is not tissue supported at all. My entire prosthesis is going to be rigidly supported only on the implant, not going to touch the soft tissue at all. So even a stock metal tray like what you saw is more than sufficient. But what you want to actually record is only the implant position. You have nothing to do with how much your labial flanges are, where your frenum is, or any of the functional impressions and muscle training which is required with the special tray is not required. If the patient was meant for a complete denture or an over denture, then I will follow all the steps meticulously. Then there is no